This was a 4-year-old who had a URI that started 8 days ago, but now is limping as well. What are some things that could be going on with this kiddo? Toxic synovitis. Septic arthritis. So those are probably your top two. Okay, so you could have a whole bunch of stuff. He too could have tumor, leukemia, osteomyelitis, cellulitis. He could have a stress fracture. He is in the age group for like Capgras disease, which we just talked about. He's also in the right age group to start presenting with juvenile rheumatoid arthritis. So things to ask on your history for this age group: is it getting better, worse, or staying about the same? If it's getting better, you can probably just watch it with close follow-up. If it's a kid who just recently started walking, so if it's a kid under the age of 2, then you could say, well, I know he's not walking. Does it seem like he's preferring to crawl on his hands or walk on his knees? Because that could point you to something in the foot rather than in the knees and the hips. So it just kind of helps you figure out where a kid is hurting in somebody who's not verbally advanced yet. Pearls on exam, the modified log roll. This helps to determine how severe the pain is. So your two differential diagnoses, your top two for this kid was septic arthritis and transient synovitis. So you lay the kid down, you grasp his foot with his leg fully extended, and you log roll both in and out. And it's more likely to be transient synovitis if you can get at least 30 degrees in each direction. If the kid won't let you move his leg even that much, then you have to be thinking just a little bit more about septic arthritis. And then a pearl on your radiographs. In a nonverbal patient who's limping, if you get just a hip to foot x-ray, you get a 20% chance of finding a fracture. So get it. Okay. Forget all the audible rules. Get a kid, just get it. Okay. So our kid probably, with his history, probably has transient synovitis. So these are the things that you want to make sure he doesn't have in order to feel comfortable sending him out the door and just seeing how he does in the next couple days. Okay? So you want to make sure he doesn't have a fever now. You want to make sure he can put at least some weight on it. Okay? And you probably want to get a CBC and a set rate. Okay? Just to make sure that this wasn't an early septic arthritis that you're diagnosed. Okay? Because you have to admit him for arthrocentesis and IV antibiotics and septic arthritis. Okay? So transient synovitis, you make that diagnosis if only 1 or 2 of the criteria for septic arthritis are present. And so rest, some children's ibuprofen, and then either call mom or see him back in the office in about 24 to 48 hours to make sure he's doing better. Okay. All right, so Dad brought in his 7-year-old who was having some leg pains that were waking her up at night. What criteria must she meet before you feel comfortable calling this growing pains and not leukemia or osteosarcoma, which is what Dad's freaking out about? This is true. It's a true one. Bilateral.
No fever?
Better during the day. Okay, so it's only occurring at night. No fever is a good one.
Growing pains are better during the day?
Yes, that is a necessary criteria. So it's bilateral, it's in the lower extremities, and it only occurs at night. If she is limping or having pain during the day, you cannot technically call that growing pains. You have to look for something else. Okay.
Next question.
Yes.
7 kind of young, or?
It's a little bit young. It's a little bit young. I tried to keep these real. Okay, caseworker brings in a 12-year-old boy who has a bump on the front of his right knee that started a few months ago, and it's kind of tender. What is this probably? Bursitis or Osgood-Schlatter. Yeah. So cartilage detachment from the tibial tuberosity. The tibial tuberosity gets real swollen. Like you can see it. A lot of times you can walk in the room and you can go, yeah, I can tell it's your right knee that's bothering you, isn't it? Sometimes it can get kind of red. It's pain that's kind of, comes and goes intermittently for several months. Most common in boys, most common in early teenage years. Another way you can kind of confirm that on exam is have them extend their knee while you resist, and it should hurt worse at that point. And this kid is fine. He just needs to maybe cut back on soccer and put some ice on it and take some Motrin and do some quad strengthening so he gets to hit the weight room for like the second half of soccer practice. So, with a note to his trainer. Do some bicep. All right. So a 13-year-old kid comes in, and raise your hand if you've seen this one. Seriously? Only 2 people? 1 person. Wow, you've seen, okay. All right, so this is very common. You're gonna see this too, particularly in like May and September. So school nurse said, gosh, I think you have scoliosis, you need to go see your doctor. So what do you do next? Yes. Okay, so you look. All right, so scoliosis is a curve defined as a curvature of the spine that's greater than 10 degrees. Okay, you classify it by the age at the time the kid is presenting. So it's infantile if it's less than 3 years of age. It's very rare. You're probably not going to see that. Juvenile, if they're between the age of 3 and 10 years old. That's 10 to 20% of all cases. It's possible you'll see that. They're more likely to progress. You're going to refer them to ortho. Okay. Adolescent idiopathic is greater than 10 years old. This is most of what you're going to see. This is 80% of all cases. Okay, so what you do is the Adams forward bend test. So you have them stand with their feet about hip width apart, and you have them slowly bend over to touch their toes. Okay, you need to stand behind them. If it's a guy, they need to loose the shirt. If it's a girl, they need to pull their shirt up to about their armpits so you can actually see the hump. You cannot adequately diagnose this through a shirt. Okay. There's some controversy over how often you need to do this. All right. The schools tend to follow the American Academy of Pediatrics guidelines, which is why you're going to see this a lot and why so many nurses refer so many kids. So the AAP suggests screening at 10, 12, 14, and 16 years of age, whether you're a boy or a girl. The American Association of Orthopedic Surgery says that is way too often. You need to do it in a girl at age 11 and then 13 years old, and you need to do it once in a boy between 12 and 14 years of age. Pick your guidelines. All right. So if you see a rib hump, that's a sign that there is curvature that's more than 10 degrees. And so your next step on this kid, you did the forward bend, there was a hump, now you gotta get an x-ray. All right, when you're looking at an x-ray, I usually ask for this on my radiographs because I know it helps me determine what I'm gonna do with this kid, as you'll see in a minute. The radiologist will not automatically give you this number. They will tell you there is mild, moderate, or severe scoliosis. They'll tell you where the convexity is, and they'll tell you what region, if it's lumbar, if it's thoracic. But they will not always give you a number associated with that. So with a kid, you gotta ask for a number. Okay? And what that number is they take the most tilted vertebrae below the apex of the curve, the most tilted one above the apex of the curve, and they draw a perpendicular line to each of those. The line in between that is the Cobb angle. Okay, so if this is greater than 10, that's scoliosis. All right, so when we're talking about degrees, we're talking about the Cobb angle. The other thing that the radiologist should be looking at least for a kid, and so the other X-ray you have to order so that you know if